Hello and welcome to the Weatherford College EMS podcast, where education meets experience and textbooks meet the street. This is going to be episode 10. I am your host, Tyler Holland, also known as the NIH Man. We've got EMS historian, Adam Parish. We've got the been there, done that career guru, Samantha Grimsley. We're kicking off with a crucial chapter for our second semester paramedic students, Pharmacology. This isn't just drug names and dosages. This is about critical thinking, patient impact, and why what you give matters. We're here to break it down, keep it real, and maybe even have a little bit of fun with it. So, we are going to be talking about antiepileptics.
Anticonvulsants.
Okay, anticonvulsants to kind of really blanket it all in.
Anti-shake juice?
Anti-shake juice.
Yeah, I think the commonality is people think when we're giving an anticonvulsant that we're stopping the seizure. Right. But we're not. Really, we're just suppressing the electrical activity in the quivering, right? So what is a seizure? I think that's the biggest thing, right?
That's when they shake, right?
Right? No. It's when the brain has so much excitation. It's like so exciting. And there's not enough inhibition in the brain. So, earlier we were talking in a couple of podcasts about glutamate and GABA, right? And so we know that excitatory factor of that neurotransmitter is coming from glutamate because it's getting overactive, like kid on candy. So while that inhibitory neurotransmitter GABA is just too quiet. So we don't have that equal balance out. And I think we were talking about this in sedative properties of what we're going to give and stuff, right? So we got to think of it like this. The brain's electrical system has the gas pedal floored and the brakes have failed. We are full force sending it. We call it in barrel racing, I'm going fast. I'm going to do full send today. So in that instance, this is where an anticonvulsant is going to say, hey, would you like some brake? Or put the parachute on or something of that sort and cut off the gas. So
it's like the e-brake.
We've already technically talked about the PAMs, the benzos, right? Yeah. But how are they going to work in relation to an anticonvulsant when we're not looking for the sedative properties like we were talking about with procedural sedation and maybe RSIing and post-intubation and things of that sort? How does that work when we're talking realistically on the neurotransmitter for seizures?
Yeah, so, with seizures, and you're right, what we're doing is we're not exactly stopping what's happening. We're stopping the physical nature of it. And one of the big problems with a seizure is that they're not really breathing all that well.
Nope. Right? And now we're giving them a respiratory depressant.
Yeah, I know. So again, we're like, hey, you can't breathe all that well, so here's something that makes you not breathe all that well, maybe... Hopefully not, though, right? Mm-hmm. Yeah, so we're going to physically give them the ability to, kind of pump the brakes a little bit. Like I said, this is the e-brake, right? You're going to pull the e-brake, takes a little bit longer, but all of that will hopefully settle down and make it to where there's not like a big refractory seizure later.
Yep.
We're going to slow stuff down, man, and
chill it out.
Chill, yeah,
It's going to restore that electrical stability. And I think the biggest thing is we have to remember that, when we're applying those brakes, those GABA brakes, we're hopefully going to make it easier for these chloride ions to start flowing and let the neurons start hyperpolarizing, and that's going to make it less negative and make the brain to start firing off and make everything chill. And I think it takes me back to the character on Cars, the hippie bus man, what's wrong, dude?
Yeah, and all of this, so the anticonvulsant activity of midazolam is related to that excess GABA. Right, and whenever it acts on those glycine receptors, it produces that muscle relaxant.
Yeah.
And with that stabilizes. It causes a, sometimes you'll hear, a drug or whatever, raising or lowering the seizure threshold. Mm-hmm. Okay, that's what we're doing. We're raising the threshold to that. We're acknowledging you're having a seizure.
Yep.
Okay, so let's put you in a position where you're not going to hurt yourself.
Yep.
And let's give you this medication that will hopefully raise that threshold high enough to where this isn't going to happen again.
Yeah. I mean, when you're talking about that threshold, lorazepam lasts longer. So we know that maybe we won't have some breakthrough kind of status. Status epilepticus. I almost said status asthmaticus, but wrong disorder right there. But nonetheless, midazolam, it hits fast, and then you've got diazepam somewhere in the middle. And honestly, when I think of diazepam, I think of rectal Valium being more in the home setting than we see anything as far as, I mean, yes, it can be used in the pre-hospital setting, but we see it more on the sedative side of things, not so much on the seizure threshold.
Not anymore anyway, right?
Yeah, it's kind of going away in a sense.
And a big thing with that was that, you know, despite what we felt like we could do, and this is going to not sound the greatest, but, you know, we as providers, I guess the medical community is the we that I'm specifically referring to, would get a patient, we would newly diagnose them, especially, pediatrics. Hey, this little guy, unfortunately, is going to have seizures. And guess what? Here's this paste that you can give them, or here's this capsule, however it was supplied, and this is when you're supposed to give it. And then they would have a seizure, they would give the medication, they would call for us, and they would wonder, why is my child gorked out?
Mm-hmm.
What is happening here? And now it's not so much that we're taking you to the hospital because you had a seizure. We're taking you to the hospital because mom and dad are not trained medical people, and they took the entire tube of Valium and applied it to their child. And because you have, it is rapid when it's given rectally, but even so, like, it's still going to be different for every patient.
Mm-hmm.
And because they say, well, I gave the bottle or I gave the tube, and you look at it and it says 50 milligrams of Valium, and you don't know exactly how much is left in the tube because it's white. It's not see-through.
Yep.
And you say, okay, well, you've just overdosed your child on Valium. Mm-hmm. We need to go to the hospital for that.
Yep.
Yeah, and even so much so, like, you made a really good point. You said kiddos, right? Mm-hmm. I think in wintertime, there's this notion that parents have to call because their kid had a seizure and they're freaking out and they think this is a new onset seizure. And it comes down to questioning and performing a great assessment. And so you get in there and you're like, well, has the child been running a fever, or do they fit that, febrile seizure? And then the next thing you ask them is like, well, yeah, they've been running a fever. Okay. And they're bundled up like they're going out in the snow tomorrow. Mm-hmm. Because I think we all know, like, as adults, we're going to sweat our fever out, but kiddos don't have that temperature regulation and know when to take stuff off if they get too hot. And parents don't know that because the kid can't tell them. But then you 9 times out of 10 will ask them, well, have you given an antipyretic yet? Have you given something for this? And they're like, well, I did, and the fever went away. And I'm like, okay, well, how long ago did you give it? Oh, I gave it like 12 hours ago. Why would you not give it again? Because now the fever, you're doing that fluctuation of the roller coaster of the temperature, and the brain is like, what is happening here, right? And so it's their compensatory mechanism to try to fight off everything, and you can only take so much of being hot. So sometimes it's not new onset seizures, but that's not our place to decide in the field setting. Even though it may look like a febrile seizure and bark like a febrile seizure, it doesn't mean it is. They could be having a new onset that we just don't know about. So don't dismiss those patients and say, like, oh, well, you're just going to go to the waiting room. They're going to give you some Tylenol or Motrin and send your child home. Like, they still need to be evaluated. Is it an emergency at that very moment? If they're not seizing, no, it's not an emergency. But we don't know when the next one is coming. We don't know anything from that sort. So best to get them there and then let the doctors do what they have to do. And most of the time it's going to be, hey, you're going to go see a neurologist and get an EEG done and all those other things, and maybe even a CAT scan if they think that it is not febrile related. But then you made up another good point about the home medication stuff. Sometimes patients just don't respond to medication, and you have to go a different route. And one of the people that I know had a VNS system in, And so they had a vagus nerve stimulator, and they knew, like, he had this history of seizures. He didn't respond to medications. He was on rectal Valium on top of everything else. But we'd go in there and we'd have to swipe the magnet or something and try to get it to stop that way. And so, just, again, a thorough assessment of these patients is huge in that sense. But I think the biggest thing that we can take to appreciate when we're talking about giving an anticonvulsant in the field is that we can go IN. We don't, in this moment when they're like this, and I love watching our paramedic students when they're trying to figure out how to treat those seizure patients, that they're like, and they're sitting there like, let me have your arm. I'm going to get this IV. And they're like, like, you're not going to get it. Good luck. Maybe the forehead that's like bulging out at this moment. But no, like, in that time, I get it. You're probably not going to get adequate vital signs. Go take a pulse if you can, or do what you best practices can. Risk versus reward is what we say here. But the biggest thing is we've got to get it to stop. They can only take the lack of oxygenation and perfusion for so long. So bump up the nose, do what you got to do, get them under control, and then start that process and being prepared. So yeah, I think that comes into play. I've been blessed. I've never really had to deal with a status epilepticus in the field setting. Have you guys?
Oh, yeah, of course. Yeah. I feel like every time that you get that seizure call, you're just sitting there thinking on the way there, man, I hope this works.
Yep. Let this medication work today.
And then you get there and, well, we've given all of the Versed. Now what?
Yeah, have you ever ran into that situation?
Of course, yeah. That's the big scary moment. Like, what now? Well, there's just a handful of options that you've got left,
and one of those things we just discussed in the last podcast.
Oh yeah,
right. They're not breathing so well.
Now we got to do something.
Now, which leads me to my next idea is, obviously, right, a paralytic is not going to stop the seizure.
Right.
They're still not breathing. They won't be shaking anymore.
That's right. Yeah. Fix the seizure.
But everything, if you open their eyes, they got that nystagmus going on, like back and forth, back and forth, back and forth.
But I mean, at the same time, right? We're talking anticonvulsants. We're talking treatment options for seizures. While that is not a treatment option in terms of addressing a seizure, if oxygenation becomes the issue, we got a solution. We got the big guns.
Mm-hmm.
Yeah.
Yep.
So you gotta, like we were talking about on the last podcast, knowing when to pull the trigger on that, and that is going to be one of those where you're gonna have to make a decision pretty quick, because an anoxic brain injury can happen pretty quickly. It could sneak up on you just like that while you're sitting there thinking, "What should I do?"
Yep. Absolutely.
Yeah, and one of the bigger things, I mean, is sitting and saying, how long do I wait?
Mm-hmm.
Right? What and part of this too is, and I hate to, get into like War Story Central here, but I had a 2-year-old that had new onset seizures that had, that was seizing. It took us 10 plus minutes to get there, and their family said they've been shaking the whole time and all that. Yeah. And then it took us 10 minutes to get there and a couple of minutes to, because of course, like, they live in the freaking back 40 down a half-mile dirt road then, Yeah. And anyway, by the time we finally got back there and got to assess and start taking care of our patient, first dose of Ativan went in, second dose of Ativan went in, third dose of Ativan went in, and during this whole time, I'll say, when we first got there, around her lips were starting to turn a little bit blue. Her nail beds were getting kind of purpley, and we were able to fix it by just giving her some oxygen. And we're like, okay, we're okay now. A few more minutes later, though, it started coming back, and we had to start bagging her. Yeah. But we were still able to oxygenate and manage that. So we were able to get to the point where the seizure did slow down, and we were on the very edge of needing to start saying, okay, I've given everything I can give. Now we have to take the next step.
Mm-hmm.
And you have to maintain those patients.
Yeah.
Because again, this is a big problem is they are not having sufficient oxygenation. They're not, their respirations have been knocked out. It's not going to work for them for very long. And you're right. To avoid that anoxic brain injury, you have to do what you got to do. Now, we have a decent list of things we can give. They're not always going to work. So I've already mentioned it a couple of times before. You got to have Plan B.
Yeah.
You got to know what to do if and when.
Right.
Yeah, so I am actually on the NIH website, and they were talking about a study they did, and it says that both intravenous lorazepam and diazepam administered by paramedics are more effective than a placebo in the treatment of adults with a convulsion status epilepticus, and intramuscular midazolam is non-inferior to intravenous lorazepam. But that more studies needed to be shown, but there was another one I was reading back from 2018, and it was showing that paramedics were more prone to doing IM Versed over anything.
Mm-hmm.
And then, the problem is what happens when you have to give an anticonvulsant. Let's just say you give a sedative, right? And you stop the seizure and they come out of their postictal period and they look at you and you're like, I don't want to go to the hospital. And you're like, well, you have this medication on board that says otherwise, and you get into that battle with them. You're like, no, sorry, I've given you something to stop your seizure. I've given you a benzo of some sort.
Yeah.
You don't have that right anymore. That does happen.
Yeah, it's a really tricky situation to get into, and depending on policy and protocol and your company's legal team and things like that, you are in a very nasty situation.
Absolutely. I mean, on the other side of the spectrum, some people might be going, well, why does magnesium sulfate in this topic, right?
Mm-hmm.
It is not the first line medication that we're going to give in our regular adult patients or pediatric patients, but it is our first line treatment of an anticonvulsant in our pregnancy patients.
Yeah.
I mean, obviously we've talked about in cardiology when we're talking about torsades and things of that sort, but the biggest thing that people forget is preeclampsia has all these signs and symptoms and all these things that come with it, but they become eclamptic the second that seizure starts,
Mm-hmm.
right? And so thinking back to when we were talking about MAG and how it works, it's blocking that calcium influx at the neuromuscular, the end. Cut that out, please.
Where?
What I'm about to say, because I totally messed it up. Let's go back to MAG.
Okay. Start from the top.
So one of the first things we talk about when we're looking at MAG, because I'm sure people are like, well, where is this playing as far as a property goes in an anticonvulsant? While it's not the first line thing we're going to give to an adult or a pediatric, it is the first line medication we're going to give in a pregnancy patient, because when we talk about preeclampsia, there's all these signs and symptoms that go with preeclampsia, but when they become eclamptic is the moment that seizure happens. And so thinking back to when we were talking about it in torsades, MAG is blocking that calcium influx at the mDNA, and this is going to reduce those excitatory neurotransmitters, which is essentially what we're doing with a benzo in our regular adult and pediatric patients, but it's going to stabilize those neuromembranes and decrease the acetylcholine release, which is a double win in a sense, right? And so we're slowing down electrical activity, we're calming the muscular irritability, and we're kind of allowing it to be that voltage regulator to the system. And we know that it's also a smooth muscle relaxer, and it's taking everything and trending it down. The problem is there's a higher toxicity level here. And we've talked about this before, especially in these patients, we talk about the loss of deep tendon reflexes, the hypotension, the bradycardia, and the respiratory depression. So you have to be mindful of knowing what you're looking for in that sense and not be too zealous with the medication. Now, that being said, if you give it, it doesn't work, you're going to have to go risk versus reward on this one and give one of the benzos to mom to stop the seizure, because if you don't have that, baby's not going to live without mom, right? And so you tried, it didn't work, now we move on. Kind of where we're at with that.
Yeah, and just talking about eclampsia, what you might not have known is that you're at your highest risk of eclampsia a week after postpartum.
Interesting.
Yeah. So do not discount the mother that has just had a baby not having seizures related to eclampsia.
That's a good thought process on that.
You know, you brought up something interesting. You talked about toxicity. Now, I don't know about you, but when I'm on an ambulance, I don't have a lab.
No.
I don't have the ability to draw up those, look really, really close and find how much mag is in there, or a machine that'll do it for me. So, something I have found though is when somebody is becoming mag toxic, and this is what I've gone with. They're going to lose their deep tendon reflexes, right? So go back, get your marker. Yeah, go assault them a little bit on their knee, right? Get them to kind of kick up at you. Take your marker. Take your what I like to use is the metal O2 key. I like the metal one; works better. And then take your marker and go ding on their knee until they kick back, and then put a little dot right there so that you don't keep hammering on them.
Yeah, it's like checking a pedal pulse.
Right, and then you come back every, I think the literature also says about every 5 minutes to come back and just boop, knock on their knee, make sure they got that kick, and move on with life.
Yeah. Yeah, seizures are one of those things that they're accounting for about 5 to 8% of the calls that we're seeing out in the pre-hospital setting. And while I know Adam and I have gotten into this conversation, we're not going to bring it up too much because we don't want to put any thoughts in people's heads, but we do know that ketamine is also starting to make its show and tell into the pre-hospital seizure protocols. It's not quite there on the EMS education standards yet or on the clinical guidelines, but we know that there's some evidence base there and some medical directors are starting to toy with it. So again, that might be something that you hear or see down the line, but it's not quite in the recommendations for full circle yet where education is saying, yes, let's put it in there. Let's utilize it in that sense. So keep that in the back of your head as, you go into the industry and you start, seeing things maybe at your capstone clinical site and they're like, hey, we do give ketamine for this. Ask them why, challenge them. Do they understand why they're giving it and kind of go that route with them? And I would say that that's pretty much what you should be doing with all medications in the clinical setting and capstone is asking the why factor. Why are you guys doing this? Do they understand what their protocols are and why they're doing something? Because we're going to come back and challenge you with that. You should be doing the same thing, and it's their responsibility to know that. I know we've talked already a lot about these medications. Is there anything else that you guys want to add in relation to as they're being used as an anticonvulsant?
One more thing to kind of bring up, we were talking about the subjectiveness in pain, but what about seizures? And you might think, well, seizures aren't subjective, and you're right, but how do you know if somebody's faking one or not? And should we give a medication to somebody that we suspect could be faking one? Or do you guys just say, you know what, let's just err on the side of caution?
Man, I have a love-hate relationship with neurologists in this because I feel like they're just feeding the person who doesn't need the candy, right? Like, you have the person who's like, I need more candy as a diabetic, and you're like, here you go, just have another one, it's not going to kill you today, right? But they're just feeding that illusion that they have this disorder where really what they need is a psychologist.
Yeah.
And they need to look at the underlying issue. Gone are the days where we were kind of jerks and put the arm up in the air and wanted to see if they would hit themselves in the face kind of thing. And I think we've done a couple, not me, but personally, but you've seen people do damage in that sense of like, oh yeah, they weren't faking it or they were. And it's like, oh, it's over here, right? Or you see the patient who's non-postictal, they haven't bitten their tongue, they're not incontinent to urine or fecal matter, they literally are talking to you the second it stopped, and you're like, yeah, no, this isn't a seizure, right? And so what I feel like is, in some sense, we've got neurologists that are feeding those people like, oh, you need medication, or you need this. You need medication, just not this medication. Or maybe you do need this Valium, but not for the reason that we're saying you need it, right? And so most of the time it's like they say, oh yeah, I have pseudo seizures or idiopathic seizure, and they know, but they don't know what they're saying. And so we come on scene and we're like, and then you'll be in the back of the ambulance and they try to do that whole like, having one right now. And you're like, no, you're not. Like,
Yeah.
breathe, chill. And sometimes it's more coaching. Taking them and saying, like we're dealing with somebody who's hyperventilating. Okay, like, look at me, focus on me, count to 10, like, take a deep breath. Like, let's just, and when you're just going to say, okay, well, here's a sedative, let me just take care of it for you, or give it in the wrong principle, you're just feeding that illusion as well.
Yeah, and one of the points I would like to make with that is we say pseudo-seizures, we see pseudo-seizures, we hear that term a lot, but what I would like to say, there's two parts really, is number one, a more, I think, polite term, because I feel like pseudo-seizure has a lot of negative connotation to it, and then you're telling the new guy, oh, they just have pseudo-seizures, well, pseudo means fake, etc., but what they're experiencing is a real phenomenon, but we're looking at it and saying, oh, there's just a faker. Psychogenic, non-epileptic seizure is one way to put it, and that completely encompasses everything you need to know. Psychogenic, non-epileptic, right? They're not having a traditional seizure, so and it doesn't carry that negative connotation with it, I think. The other point I would like to make is, like, you see somebody diagnosed with depression and they're crying or what have you, you're not going to go, stop it right there, you know? So we need to treat these people with empathy still, but maybe not, accuse them or whatever it might be and say, oh, you're just after my narcotics.
Yeah, it's like telling the patient who has sickle cell disease that they're just after pain management, right? Like, we know they're hurting and we know that their threshold may be a little bit higher, and so they need a higher dosages because they're used to being on medication, but telling them, like, oh, you're just faking it. You know, that's not our place in our judgment to utilize, but you make a good point. Being empathetic and having that effective ability, because we don't know. Maybe this is brought on by PTSD that we don't know, sexual trauma, traumatic trauma. We have no idea what the case may be. And so, you know, I just don't want to say go load them up with medications and say, okay, well, that's the problem, because realistically, what if it's something else that they're really needing?
Exactly.
You know?
Yeah, the use of some of these benzos that we've been talking, anticonvulsants that we've been talking about, you know, they can on a psychological level, they can really help a patient that's, you know, that's experiencing anxiety. I know I talked before about Valium, like that was a big usage of Valium. In fact, there was, I saw when I was doing my research a poster of it was in the 1960s that they were saying, just take a Valium and feel better.
No.
And it was supposed to be this thing, right? And it's just like, she's sitting there with a big smile, taking a pill with a glass of water, right? And
Or
it's
sell it.
yeah. Well, and so you know, so those things can also have those kind of psychological things where all they really know is, I'm stressed out. The paramedic, I feel bad. I have a seizure. The paramedics show up. They give me that medicine, and all of a sudden, I feel a lot better. And yes, that might be what they're after. One of the things that I like to harp on, though, is I always go back to, you know, like the pain management side of things. If you tell me you fell and you tell me your back hurts and I feel on your back and I don't feel anything wrong with your back, doesn't mean that you're not hurting still, right?
Yeah.
If, in my opinion, it looks like you're having a seizure, I just try to go easy on it, right? If it looks like a duck, quacks like a duck, I'm going to treat it like a duck.
Agreed. Yeah.
And I'm going to move on. Now, if you start seeing things like they're talking during their seizure, things like this, okay.
Yeah.
Maybe not so much. Maybe wait for the big hitter to come out.
You got to think, like,
right?
What's the purpose? Like we were talking about, what's the purpose of the drug, right?
Right. Well, and not only that, but what's the situation that your patient was, you know, what was the situation your patient is in, right? In my county, we had a patient that would have these all the time when she was at work.
Yeah.
Right? She would be at work, they'd get really busy, she'd get stressed out, fall to the ground, have a seizure.
Mm-hmm.
By the time we get there, she was always awake and like, oh, yeah, I guess I should probably go to the hospital or go home. I don't know. I was stressed out today. I had a seizure.
Yeah.
And you start saying, well, okay, but if you're having seizures, you need to go to the hospital.
Yeah, we need to do something at this
Right?
point.
But for that patient, I'm still not going to show up with, a syringe full of Ativan and say, here you go.
Yeah.
Right? So in determining that, it is difficult at first, but at the same time, use your judgment.
Mm-hmm.
If you're in doubt, treat the problem.
Exactly.
Treat the treatable, right?
Yeah.
Don't withhold something just because you've convinced yourself. If you've had to go out of your way to convince yourself that what you're seeing is not what you're really seeing,
Mm-hmm.
or what you perceive is not truly an emergency, and you talk yourself out of it, that's where people get in trouble.
Yeah.
Because honestly, like, if you put me in that kind of situation and you said, hey, this guy may be faking, and I say, well, what's your evidence? And they say, I thought he was faking.
Mm-hmm.
Cool. That's why you decided not to give this patient this medicine? That's a terrible argument.
Oh, yeah.
You are going to lose that argument.
Absolutely.
And if that's all you have, again, cover your butt.
Yep.
Mm-hmm.
Okay? If it walks like a duck, talks like a duck, if you have to convince yourself that that's what's happening, you're probably wrong.
Yeah.
Go ahead and just treat it. At the same time, though, if they're talking, if they're walking, if they're sitting there walking down the road and they're like, I'm phasing,
Mm-hmm.
you can side-eye that all you want, right? But
Right.
That's about all I got on that.
All right. Well, that's a wrap on this episode of the Weatherford College EMS podcast. Big thanks for tuning in as we kicked off this topic in the last part of neurology, really, honestly, with anticonvulsants. It's a topic that can feel intimidating, but we promise it gets clearer with every call and every repetition. From Tyler, the NIH man, to Adam, the historian, to myself, the field-tested perspective, we are here to guide you through it every step of the way. Stay curious, ask questions, and never stop connecting the dots between the meds, the pathophysiology, and the patient. Until next time, stay safe, stay smart, and don't forget, it's not just about knowing the drugs, it's about knowing what they do and why. Have a great day, everyone.